Now, it's a continuous series of obstetric. Now, gestational diabetes mellitus. Why it happens? Due to human placental lactogen. Due to human placenta lactogen secretion. When it should be screened in 24 to 28 week of gestation. It should be screened on 24 to 28 week of gestation. This point is very master high yield. 1 hour of 50 gram GCT and 3 hour of 100 gram GCT. So human placental lactogen secretion causes this gestational diabetes mellitus should be screened in 24 to 28 weeks of pregnancy. Management: first line diet, second line insulin, glyburide and metformin. Glyburide is a sulfonylurea and metformin and metformin is a biguanide. Okay. Target blood glucose fasting less than 95 1 hour postprandial less than 140 and 2 hour postprandial less than 120 less or equal 120. So fasting less than 95 1 hour less than 140 and 2 hour less or equal 120. Postpartum management: glucose fasting glucose at 24 to 72 hours, fasting glucose at 24 to 72 hours, and 2 hours after GTT at 6 to 12 weeks of visit. GCT is glucose challenge test and GTT is glucose tolerance test. So 1 hour GCT glucose challenge test and 3 hour GTT. That means glucose tolerance test should be done in this case. So for gestational diabetes mellitus, first thing you have to remember that human placental lactogen secretion is a cause of having these gestational diabetes mellitus, and it should be screened when it should be screened in 24 to 28 weeks of gestation. Okay, now all women require screening at 24. All women require screening of 24 to 28 weeks of gestation because GDM is associated with increased risk of hypertension, preeclampsia, macrosomia, and cesarean delivery. Okay, patient with risk factors benefit from earlier screening, early second trimester, rescreening at 24 to 28 weeks if initial screening is negative. Patient with some sort of risk factor, they should be screened earlier, and again they should be screened at 24 to 28 weeks of gestation. Target range: fasting should be less than 95 hours after 140 and sorry 1 hour after 140 and 2 hours after less than 120. Insulin is the first line pharmacotherapeutic drug because it doesn't cause the blood placental barrier and dose is easily adjustable. Oral antiglycemic medicine by guanide metformin can be given, and sulfonylurea glyburide can be used. So metformin and glyburide can be used. May be used who decline in insulin and have difficulty administering or adhering to insulin therapy. An early glucose challenge test. In early glucose challenge screens for undiagnosed pre-gestational diabetes mellitus and is indicated in patients with BMI more than 25 kg per meter square and additional risk factor. If BMI is more than 25, an additional risk factor like prior GDM, prior first degree relatives of type 2 diabetes mellitus. A first degree relative with prior gestational mellitus is not an indication for. Okay, it's a two-way approach. 24 to 28 weeks, administer 50 gram of oral glucose challenge test. Check glucose 1 hour later. If blood glucose is less than 140, gestational diabetes mellitus unlikely, no further testing should be done. If blood glucose is more than 140, administer 100-gram glucose load. Check fasting glucose. Check fasting glucose. Check fasting glucose each hour afterward 3 hour each hour afterward 3 hour. Then you should be seeing this. So fasting more than 95 1 hour after more than 180 1 hour more than 182 or more than 155 and 3 hour more than 140. 140 or 145 national diabetes data group criteria. If 3 or more than 145, diagnosis done. It's a diabetes, gestational diabetes. So first 50 gram 1 hour glucose challenge test. Oral serum glucose. If serum glucose is more than 140, then 3 hour test should be done. Oral glucose load test. Oral glucose load test, check fasting glucose each hour after 3 hour, and this should be thought. During the third trimester of pregnancy, the fetus has an increased amount of glucose and other nutrients due to accelerated growth and increased metabolic need. Physiologic adaptation of pregnancy include pancreatic beta hyperplasia and increased insulin secretion, increased peripheral glucose resistance, and human placental lactogen, a placental somatomammo- somatomammotrophine has increased production of third trimester, resulting in pancreatic resulting in pancreatic beta cell hyperplasia and increased glucose resistance. Gestational diabetes mellitus occurs when peripheral insulin resistance exceeds pancreatic insulin secretion, resulting in pathologic maternal hyperglycemia. Screening for GDM with 1 hour glucose challenge test occur at 24 to 28 weeks of gestation, mm, to correspond with the human placental lactogen production. The diagnosis is confirmed by 3-hour glucose challenge test. Treatment of GDM is important because glycemic control improves pregnancy and neonatal outcome. Maternal hyperglycemia is associated with increased rates of fetal macrosomia. Maternal hyperglycemia is associated with fetal macrosomia, cesarean delivery, and neonatal hypoglycemia. GDM results after placental delivery due to cessation of HPL production, as HPL is the main culprit when you deliver the placenta. The source gone, the diabetes gone. Then hypertension, pregnancy related risks due to hypertension. Pregnancy related risk due to hypertension. It may be maternal, it may be. Okay. Pregnancy related risk due to hypertension, superimposed preeclampsia, PPH, gestational diabetes, apraxia placenta, and cesarean delivery. And fetal growth restriction, perinatal mortality, preterm delivery, and oligohydramnios. Maternal is superimposed preeclampsia, PPH, gestational diabetes, abruptio placentae, and cesarean delivery. And fetal is fetal growth restriction, perinatal mortality, preterm delivery, and oligohydramnios. These box, this is another, this is another high yield emergency box. You have to remember that hypertensive disorder in the pregnancy. In hypertensive disorder in pregnancy, it may be chronic hypertension that may systolic more than 140 and diastolic more than 90 prior to conception or 20 or before 20 weeks of gestation. If if systolic blood pressure more than 140 or systolic more than 140, diastolic of more than 90 or more than 90 prior to conception or 20 weeks of gestation, that is chronic hypertension. Then gestational hypertension is new onset elevated blood pressure at more than 20 weeks of gestation, new onset elevated blood pressure at 20 or more than 20 weeks of gestation, no proteinuria or end organ damage, no proteinuria or end organ damage. Preeclampsia preeclampsia is elevated blood pressure at more than 20 weeks of gestation, and more than 20 weeks of gestation, and proteinuria or signs of organ damage. And eclampsia is preeclampsia and new onset grand mal seizure, and new onset grand mal seizure is eclampsia. Preeclampsia is new onset elevated blood pressure at more than 20 weeks of gestation, and proteinuria or signs of organ damage. And eclampsia is preeclampsia and new onset grand mal seizure. Now, chronic hypertension with superimposed preeclampsia. Chronic hypertension and one of the following: new onset proteinuria or worsening existing proteinuria at more than 20 weeks of gestation, and sudden worsening of the hypertension, and signs of organ damage. What is white coat hypertension? It is white coat hypertension is very unlikely with diastolic pressure more or equal than 105. Chronic hypertension, the drug beta blocker or calcium channel blocker, nifedipine, hydralazine, and methyl dopa. Second line is clonidine and thiazide diuretics. The drugs which should not be given, in pregnancy. These are the things you should be remember. ACARB, direct renin inhibitor, nitroprusside, ACERB, direct renin inhibitor, nitropocine, and spironolactone. In pregnancy, chronic hypertension is hypertension diagnosed prior to or during the first 20 weeks of gestation. Chronic hypertension diagnosed during prior to or during first 20 weeks of gestation or pre-existing more than 12 weeks of postpartum and pre-existing more than 12 weeks of postpartum. So what is chronic hypertension? In chronic hypertension, if pregnancy diagnosed before 20 weeks of gestation, prior to or during the first prior to or during the first 20 weeks of gestation, or pre-existing more than 12 weeks of postpartum. Chronic hypertension confers that an increased risk of maternal and fetal complication like superimposed preeclampsia, preterm birth. To make a diagnosis of chronic hypertension during pregnancy, blood pressure should be elevated. Two measurement taken. Blood pressure should be elevated. Two measurement taken 4 hours apart. 4 hour apart. Extended release nifedipine safe in pregnancy. Immediate release nifedipine may cause rapid drop in the blood pressure. So extended release nifedipine is safe in pregnancy. Very high health talks are going on. When we are choosing drug, we are just not that much of careful about the release, about the standard protocol. If we don't do so, there may be a major problem. If after conception the patient blood pressure decreased significantly due to physiological adaptation like decreased systemic vascular resistance, the medication may be reduced or discontinued. Recommended alpha antihypertensive during pregnancy include beta blockers, especially labetalol and methyldopa. Hydrolyzing calcium channel blocker are acceptable alternate therapy. Beta blockers are the safest in pregnancy. Mm, include labetalol, pindolol, and long-acting metoprolol. For non-pregnant women with hypertension or no other indication, coronary beta blocker are not recommended. However, non-pregnant women beta blocker are not recommended as first line because they are associated with less reduction in risk of stroke and mortality compared to other agents. So beta blocker are safest in pregnancy, but for non-pregnant, we actually don't choose beta blocker. They have that not. Okay, thiazide, chlorothalidone is avoided due to pregnancy risk of decreased maternal blood volume and potential reduced placental perfusion. They are second line agents. Sometimes continued at patients who are already pregnant were taking them prior to the pregnancy. Patient considering pregnancy should be switched to a first line agent. Spironolactone cross the placenta and have potential anti-androgenic effects on male fetus and therefore not recommended for women who are pregnant and planning for pregnancy. Spironolactone should not be used. This is the risk factors of preeclampsia. This box is a emergency high yield topic we would like to discuss. Nulliparity, obesity, pre-existing medical condition. Nulliparity, obesity in preeclampsia. What are the risk factor? Nulliparity, obesity, pre-existing medical condition like SLA, chronic hypertension, diabetes mellitus, multiple gestation, advanced maternal age, and prior preeclampsia. Nulli, multiple VCD, pre-existing, advanced maternal age, and prior preeclampsia. New onset hypertension, systolic blood pressure more than 140, and diastolic more than 90 at more than 20 weeks of gestation, with proteinuria with or without organ damage. This is the definition of preeclampsia. And the risk factors are nulliparity, multiple gestation, obesity, pre-existing medical conditions like SLE, chronic hypertension, DM, multiple gestations, advanced maternal age, prior preeclampsia. This feature, this is another high yield. This is another high yield final thought in remembering the severe feature. Severe feature is severe range hypertension, systolic more than 160, diastolic more than 110, systolic more than 120, 160, diastolic more than 110, platelet less than 1 lakh, platelet less than 1 lakh, creatinine 1.1 milligram per dl, elevated transaminase level, elevated transaminase level which is elevated transaminase level 2 times the upper limit. Pulmonary edema, visual or cerebral symptoms. Pulmonary edema, visual and cerebral symptoms. Pulmonary edema and visual or cerebral symptoms. Management is less than 37 weeks and no severe feature which is expectant. 37 more than 37 weeks, less than 37 with no severe feature, expectant delivery 37 weeks, or 34 weeks with severe feature like these. Systolic more than 160, diastolic more than 110, systolic more than 160, diastolic more than 110. There may be low platelet like mild thrombocytopenia, that means less than 1 lakh, creatinine more than 1.1, elevated transaminase 2 times the upper limit, pulmonary edema, and visual and cerebral symptoms. Severe range blood pressure IV, labetalol IV, hydralazine, oral, nifedipine, and severe prophylaxis, Maxalf IV or IM should be given on two measurements for more than 4 hours apart, more than 4 hours apart. Urine protein ratio more than 0.3 and hypertension more than 20 weeks. Okay, hypertension more than 20 weeks of gestation require preeclampsia. All patient hypertension more than 20 weeks of gestation require preeclampsia. Blood pressure measurement, clinical sign if there is any headache, visual change, labs, urinalysis, fetal well-being, non-stresses. These four things should be done. If you get a patient with hypertension more than 20 weeks of gestation, what should we do? If patient has a normal lab evaluation, urine analysis, only 1 plus 2 plus actually diagnostic and high rate of 24-hour protein is a gold standard to diagnose preeclampsia and establish baseline management. In the brain, endothelial cell damage and precipitate. In the brain, endothelial cell damage and precipitate acute stroke via the mechanism. Preeclampsia can present up to 6 weeks of postpartum. So postpartum preeclampsia can happen with headache and hypertension. Patient with preeclampsia can have increased risk of stroke also. Very high health. Most preeclamptic patients do not require imaging. However, in those focal neurological deficits, asymmetric motor deficit, and strength, the right is more than the left. CT scan should be done to evaluate for possible stroke and help to diagnose. Maxilp is contraindicated in patient with this one is very high thought. In myasthenia gravis, Maxilp should be contraindicated because it may trigger the myasthenic crisis due to inhibition of the acetylcholine reserve. Because patient with Maxilp toxicity typically have absent plantar reflex, respiratory depression. Toxicity can progress to respiratory paralysis, cardiac arrest. Treatment is cessation of the Maxilp and administration of the calcium gluconate. Okay, preeclampsia prevention. What is preeclampsia? New onset hypertension after 20 weeks of pregnancy with proteinuria with or without organ damage. A high risk are prior preeclampsia, CKD, chronic hypertension, DM. High risk are prior preeclampsia, CKD, hypertension, DM, multiple gestation, and maybe autoimmune motor disease, obesity, advanced maternal age, obesity, advanced maternal age, and nulliparity prevention, low dose aspirin. These were low dose aspirin at 12 weeks of gestation is high yield for preeclampsia. It should be initiated 12 to 20 weeks of gestation. Then it should be continued until delivery. Twin gestation increases the risk of preeclampsia nearly threefold and possibly due to greater placental mass and subsequently a higher risk of placental hypoperfusion, placental hypoperfusion leading to placental ischemia in patient and high risk for preeclampsia, type 1 diabetes mellitus, multiple gestation, a 24-hour urine collection for total protein at initial visit, at total protein at initial visit, first semester, establish a baseline pre-pregnancy proteinuria assessment. The ability to evaluate the changes in proteinuria levels help to determine whether blood pressure elevation later in pregnancy are due to gestational hypertension or okay. Patients with gestational hypertension are typically managed as outpatient and delivered at 37 to 30 weeks of gestation. In contrast, patients with preeclampsia may require inpatient and possible preterm delivery, less than 37 weeks of gestation. New onset severe hypertension more than 160 and has more than one preeclampsia with severe feature. So new onset hypertension, systolic more than 160, diastolic more than 110, and during pregnancy is recognized as preeclampsia with severe features. Severe hypertension increased maternal risk of stroke, pulmonary edema, and myocardial ischemia. First line is IV labetalol, a beta blocker with an alpha blocking ability, a beta blocker, both alpha and beta blocker. Mhm. First line in patient with bradycardia less than 60, beta blocker labetalol can further decrease the heart rate, resulting in dizziness and lightheadedness. There may be dizziness and lightheadedness. IV hydralazine, a direct arterial vasodilator. Direct arterial vasodilator, hydralazine can cause tachycardia due to sympathetic nervous system stimulation. Oral nifedipine calcium channel blocker. Although oral nifedipine can rapidly lower blood pressure, these patients may not be tolerate oral medication due to nausea and vomiting. A 24-hour oral protein correlation can assess for preeclampsia, and antepartum diagnosis of preeclampsia increases the risk of persistent preeclampsia and eclampsia uh, up to 12 weeks of gestation. Eclampsia up to 12 weeks of gestation. This is the pathogenesis. This is this is spiral artery. This is vessel remodeling, cytoblost invasion. This is cytoblost invasion. No, in normal pregnancy, cytoblost in vessel remodeling. As there is in preeclampsia, there is abnormal cytoblost invasion. So no vessel remodeling, no vessel. So there is decreased perfusion and increased. So there is decreased perfusion. And increased androgenic and pro-androgenic features and widespread material endothelial dysfunction vasospasm. They all that leads to hypertension. Preeclampsia likely occurs due to insufficient trophoblast invasion. Preeclampsia likely occur due to insufficient trophoblast invasion, abnormal trophoblast invasion resulting in low uteroplacental perfusion. In contrast, patients with placenta accreta have excessive trophoblastic infusion and placenta hyperperfusion, numerous lacuna. This word is very master high yield. This word is a master high yield. So in contrast with placenta accreta, there is excessive trophoblastic invasion as it attaches to the myometrium, thus causes placental hyperperfusion, numerous lacuna. Helps in preeclampsia, nausea, vomiting, right upper quadrant pain. There may be microangiopathy, hemolytic anemia, elevated liver enzyme, and low platelet. Microangiopathy, hemolytic anemia, elevated liver enzyme, low platelet delivery. Max Cell for seizure prophylaxis, antihypertensive drug, help syndrome, nausea, right upper quadrant pain, headache, visual changes, hypertension, microangiopathy, hemolytic anemia, elevated liver enzyme, thrombocytopenia, proteinuria deliveries, Maxal for seizure prophylaxis, and antihypertensive hydralazine. Complication is abdorsal placentis, subcapsular liver hematoma, acute renal failure, pulmonary edema, and DIC and DIC. In HELP syndrome, this process can cause liver swelling due to distension of the Gleason's capsule. This Gleason's capsule resulting in resulting in right upper quadrant pain. The diagnosis based on clinical presentation labs. Diagnosis based on clinical presentation and labs. Acute fatty liver of the pregnancy is a microvascular fatty infiltration of the hepatocyte. This happens due to microvascular fatty infiltration of the hepatocyte can cause elevated transaminase and thrombocytopenia. There is prolonged PTT, PT, and prolonged hypoglycemia. This is pulmonary edema. This is a life-threatening complication of severe PE. This is life-threatening complication of severe PE. Pathophysiology. Pathophysiology is generalized arterial vasospasm, increase afterload, and against the heart is pumping, increased pulmonary capillary pressure, pulmonary edema, increased pulmonary capillary pressure, increased pulmonary, decreased albumin, decreased renal function, increased vascular permeability. So management, supplemental oxygen, fluid restriction, diuresis is severe cases. In pregnancy, usually we avoid diuresis, but in such cases, in severe cases, you have to give diuresis. Fluid restriction and diuresis must should be in caution as plasma volume is effectively decreased through the third spacing and placental perfusion may be compromised in third spacing and placental perfusion may be compromised. Eclampsia is preeclampsia and new onset seizure, hypertension more than systolic more than 160, diastolic more than 110, seizure, severe headache, visual disturbance, hyperreflection, proteinuria. If you do CTs, there is bilateral frontal lobe edema. There is bilateral frontal lobe edema. Maxil can be given, antihypertensive should be given, and delivery should be done. Whatever the trimester, if the seizure is not controlled, then whatever the trimester, you have to deliver the patient. Acute fatty liver of the pregnancy, nausea, vomiting, right upper cord pain, and fulminant failure. In acute fatty liver of the pregnancy, this can cause fulminant liver failure. It may be prolonged hypoglycemia, aminotransferase should be 3 times higher, bilirubin higher, thrombocytopenia, then be DIC. Acute fatty liver of the pregnancy, ASTLT higher, thrombocytopenia, there may be DIC features, there may be bilirubin high, prolonged hypoglycemia, immediate delivery should be done. Immediate delivery should be done. Immediate delivery should be done. Intrahepatic cholestasis of the pregnancy develop in the third trimester. Generalized pruritus worse on hands and feet, no associated rash, and there is right upper quadrant pain. Increased total by this is very high level pruritus on hands and feet, no associated rash, right upper quadrant pain, total bile acid more than 10, increased liver MMS, typically less than typically less than 2 times of the normal and total or direct bilirubin. Obstetric risk is higher. Intrauterine fetal demise preterm meconium stent, amniotic fluid, and neonatal respiratory distress syndrome. In such case, you should give arsocol, ursodeoxycholic acid intrahepatic, ursodeoxycholic acid delivery at 36 weeks of gestation. These are the high yield topic. This is a very high yield topic. In intrahepatic cholestasis of the pregnancy, you should give ursodeoxycholic acid. Diagnosis done, total bile acid more than high, liver MNS less than 2% normal, and total bilirubin. Topical corticosteroid are given in polymorphic eruption of the pregnancy. This is polymorphic eruption of the, this is polymorphic pruritus, erythematous plaques, spare the periumbilical region, spare face, palm, sole, spare face, palm, sole, and develop in the third house. Polymorphic eruption of the pregnancy. In polymorphic eruption of the pregnancy, polymorphic usually happens in the pregnancy. It is pruritus, usually Uh, Spears face, palms, soles develop in the third trimester clinical. Topical corticosteroid should be done and antihistamine should be given. Topical corticosteroid and antihistamine. No adverse outcome of pregnancy. Polymorphic eruption. Periumbilical. This is polymorphic eruption of the pregnancy. Periumbilical sparing. Erythematous papule and striarythematus papule, also known as pruritic. It is pruritic polymorphic erythematous papule in stria that develops in the third trimester. PEP, polymorphic eruption of the pregnancy when overstretching of the skin causes connective tissue damage. And that's the series of the lecture. Hope you enjoy.